being deployed for Hurricane Matthew in 2016. Dr. Chrisman is a Distinguished Fellow of the American Academy of Child and Adolescent Psychiatry, a Distinguished Lifetime Fellow of the APA. His publications include co-authorship on the 2013 Practice Parameter on Disaster Preparedness for the AACAP, Child Disaster Mental Health Interventions Part 1 and 2, and then recently he was sharing with me that he's contributing to the up-to-date publicly available resources for disaster social services. Dr. Chrisman continues to serve as the chair of the NC Psychiatric Association Disaster Committee. So I think it should come as an obvious statement that he's exceedingly well qualified to talk about disaster mental health, and as it turns out now, as any time, is a pretty good time to think about disaster and services to treat people who are undergoing various disasters. So please welcome Dr. Allan Chrisman, who will teach us about disaster mental health sheltering.
Well, it's nice to be back with colleagues and friends. Let me quickly get to the heart of the matter here. For the first time, I can say I have no conflicts of interest. What I'm going to talk about today is going to be a bit of an introduction to the overall context of disaster circumstances and response, talk about special needs populations, talk about the movement into community-based care and the implications it's got for our response to the community, especially around sheltering. Everyone is welcome is the Red Cross shelter philosophy, and I'll talk some more detail about that. And I'll go through a description of the instrument that's being used called CMIS that FEMA is promoting also to help understand exactly what the needs are of individuals coming into shelters. And then there are some very specific aspects to shelter work experience that includes working with domestic violence and also the role of service animals, which is generally now talked about a lot no matter where you travel. So let me introduce this global topic in a way by emphasizing the following. We are at this stage of this hurricane season seeing effectively 1/4 of all of the Category 5 hurricanes that have been recorded in the Atlantic since 1851. That is a pretty big, important fact for us. And Category 5 hurricanes are the most destructive, and they have peak winds of about 157 miles per hour. A high percentage of framed houses will be destroyed with total roof failure, wall collapse, fall trees, power lines down, and power outages that will last for weeks. I think it goes without saying that the full impact of this is now being realized in Puerto Rico, and that is effectively going to be their circumstances for months to come. I want to give you a little bit of a pictorial context for what it's like doing shelter work when you have such a disaster. Some of these slides I'll quickly go through come from the Red Cross. I was deployed in the Baton Rouge flood, and the mega shelter I was in was very similar to this one that's depicted here. That's in Houston. And this is not an uncommon sight. So we're looking at, again, this is a more standard, not a mega shelter circumstance, how the cots are aligned in rows. This is a typical feeding situation. And as a Red Cross responder, regardless of what your role is, you may well end up supporting and helping out with these feeding circumstances. It's an example of a family from Hurricane Irma. So the role here in these circumstances of both disaster mental health and disaster health services, Red Cross volunteers, is I sort of boil it down to sort of 3 domains. There's a lot of case management that you do, there's a lot of advocacy that you do, and then there of course is a underlying ongoing psychological support that you're trying to provide. So the promotion of the resilience and coping is now well developed as an enhanced psychological first aid. I ran into Mehul in the lobby. He's on his way down to Georgia talking about physician burnout. And he asked me, was I going to say something about critical incident debriefing? And my comment to him was that psychological first aid actually was developed in response to the fact that studies showed that critical incident debriefing, as it was disseminated sort of unwittingly, was actually harmful more often than not. And so recognizing that that was the only kind of vehicle in general that was being utilized at the time, folks from the National Child Traumatic Stress Network and other areas got together and created this basic format. And there are 5, so there's a lot of detail here, and when you become a volunteer, they have you get trained in it. The best website that I've seen that has free training is at the National Child Traumatic Stress Network. But the detail of this can be boiled down to basically 5 components, and the goal of those is to create a sense of safety, create calm, create self and collective efficacy, create a sense of connection, and then create a sense of hope. This is taught for all people that work in the Red Cross, and I think in many respects has been disseminated in a lot of the actual expectation of training that you get here at Duke and the VA. So let's talk about the special needs population. So I'm going to focus down at this point on the primary goal of this talk, which is to talk about how can we, in a sheltering situation, one that's pretty chaotic, that often is massive, both identify and respond to the most vulnerable people. Providing shelter, again, for vulnerable and special needs populations in an emergency, it's really one of the most difficult challenges for disaster planners. And what we have come to appreciate is that the elderly, children, the disabled, and those with cognitive or sensory impairments or other special medical needs may need special attention when staying in shelters. My experience starting in Baton Rouge and, Katrina and then Baton Rouge and Hurricane Matthew, it has reinforced the fact that you don't know what the level of need is of the individual that you're going to be trying to help. And the best way to sort of get that clarified is through systematic assessment. And so that's why these other instruments were developed. So looking at the concept of what a disability is, I think there's a common sense approach that's worth going into, because there's a lot of legal stuff with the American Disabilities Act that sometimes is a little hard to anticipate. But in general, we're looking at an individual who has a physical or mental impairment that substantially limits one or more major life activities that an average person can perform with little or no difficulty, and that there's a record of such an impairment or is regarded as having such an impairment. And the law further defines these terms for mental impairment, and that includes most psychological disorders and disorders such as organic brain syndrome, learning disabilities, and emotional or mental illness. It specifically excludes various sexual behavior disorders, compulsive gambling, pyromania, and disorders due to current use of illegal drugs. I think my caveat on that last comment is, as we all know, substance abuse is a significant comorbidity, and it is something that we don't ignore, that we incorporate it in our efforts to help people. But I will say that one of the bigger dilemmas in sheltering circumstances, when there's often a shortage of the prescribed medications, is that the first people that show up for business purposes, very entrepreneurial, are the drug dealers, and they hang outside of the shelters, and the people that are often acutely distressed, if you don't work with them, are going to be out there buying drugs and making things worse. So let's talk a little bit about the population again in terms of the folks that have mental disorders or distress. We know that from the National Institute of Mental Health that 26.2% of the U.S. adult population will have a mental disorder within a given year. That's a pretty significant figure. It's even higher for children and adolescents, actually. And of those, 22.3% will be diagnosed as severely mentally ill. So if you take that figure and then you think of where are we, which is in the southeast, then you find out that in fact there's a higher prevalence even here, and that is somewhat, I think, thought to be related to the fact that we have higher areas of poverty, we have a lot of rural areas, and when there is very often comorbidity with physical health conditions. So the issue of access to care and the issue of toxic stress, I would call it, related to poverty and rural circumstances are major contributors to this. So here we have a defined problem with the pretty frequent occurrence of these types of disorders, and now about what is the context that we have within which we're trying to care for people. So we have in the past, in the 1960s, this deinstitutionalization of mental illness, and the intent was to serve those with severe mental illness in the least restrictive environment and to integrate into society individuals and so they can live independently and have community-based outpatient mental health support. That didn't work out too well. We have people out of the hospital, but that doesn't mean that they're accessing and getting the level of care that we had envisioned. So as a result, individuals with mental illness are now dependent upon community-based resources, not only for their routine mental health care, medication and monitoring, but also information about public health concerns and awareness. There was, the state was remiss in stepping up to say what they were going to do, and there was a lawsuit, and as a result, the state of North Carolina entered into a settlement agreement with the Department of Justice in 2012. The reason I put that in here is that effectively required the state to stop warehousing adults that had serious mental illness that were discharged from the hospital in collective group homes where they were basically getting any services. They were required to get them out of those group homes into more appropriate community settings, apartments, and assign them caseworkers and provide connections to mental health services. And there was a pot of money that had to be set aside for that. With this agreement, it meant that also the circumstances in the disaster sheltering situation that we're more likely now to have people closer in the community to where the shelters are going to be set up. We know that in terms of addressing the needs of the seriously mentally ill in a disaster situation, that they are less prepared. They often are faced with the onset of new and recurrent symptoms. They have a disruption of any health service care that they might have had. There's a tendency for them to lose caretakers. Mental health services are disrupted. Again, there can be also a loss of hospitals and care facilities. And I know that for sure in Puerto Rico right now, that is a actual huge humanitarian crisis. I think almost a quarter of the hospitals are only operational at this point. And they are in serious trouble with even the ability, without a lack of power, to refrigerate and even keep insulin available. So that's a very, it's a life-threatening circumstance. And then, so of course, we have increased need for demand for mental health services under these circumstances. So if we take those facts and then we take a look at an individual with a serious mental illness and the impact on families, which is really the primary source of a lot of support for people in disaster circumstances, we find that the strain of the mental illness commonly places difficulty with the family relationships, and that as a result, those with severe mental illness are often less likely to have an appropriate functioning family member closely involved in their day-to-day care that's aware of their, not only their diagnosis and current functioning, but what meds they're taking, and also whether they are taking them, and they really very unlikely to have discussed a disaster plan. So there's an isolation from care that we're seeing now presently. Positive social interactions are even less likely for individuals in the community whose mental illness remains undiagnosed or otherwise untreated and not engaged in the system of care. And then again, we have a scenario where rural settings may provide an advantage of low cost of living and a low population density, and for people who have mental illness, they often want privacy and anonymity, so there's a sort of adverse selection often for people who tend to drift into rural settings. But it also means that there's reduced access to daily interaction with others, increased isolation, and limited access to mental health care. So what does that mean in terms of thinking about the kind of care that very often is critical to their stabilization and recovery? Well, we think about psychotropic medications as being an important element here. We know that the comorbid limited cognitive abilities that often goes with severe mental illness and or the use or misuse of substances will further compound these problems for mentally ill. And so their ability to adhere to taking their medications as prescribed, if prescribed, is also a problem for their being able to manage their own illness, and it really decreases the likelihood of independent functioning. And then there are also problems with prescribing restrictions and medication costs that results in they're not even likely to have a reserve of medications for, say, more than a month. So it's not uncommon for people, even if they are dutiful in their ability to adhere to the treatment and to have a case manager, to whether or not they have access to a refill on their meds and where they are in terms of how many meds they have on board and how they can continue to access it when they're in the shelter is a huge problem. We also have, of course, the dilemma where there's a self-continuation of medication, and that might be just because of a failure to refill or renew a prescription. They can't get to the appointment, or they forgot it. And as a result, you can see adverse medication side effects that it can be from withdrawal if they stop, or that might be a reason for them to stop because they're getting more prolonged types of problems such as tardive dyskinesia with some of them. So it's not uncommon for individuals with mental illness to self-continue, again, because they might be feeling better. So what goes with this is that in a real crisis, in a real disaster scenario, an acute phase, where there's a sense of almost heroic response by members of the community, there can be a kind of sense of, I don't know if I'll call it normalcy, but a lot of the folks I've talked to look around, see how upset and distressed everybody else is, and they're like, well, you know, so I'm not doing bad. Maybe I don't need my meds, and they thought they'll, you know, do a trial period off of them, which unfortunately doesn't go too well. So the consequence of all of that is that it may not be known whether those with mental illness in the community are engaged in treatment and whether they're taking their medications as prescribed when they show up to the shelter. So we want to look at the issue of stress in these circumstances as well. We know that the impact of stress, which we think of as an acute stress disorder for a lot of folks, may exacerbate the pre-existing symptoms for those with mental illness. Some individuals who refuse to leave their homes, often despite being unsafe and maybe unable to be around unfamiliar people, or they can't be in crowded environments, can be a component of that stress reaction. And attempts to evacuate them to safety or to a designated shelter may indeed further result in an increased agitation and distress. So we're going to have now, under these conditions, not only an individual that's more agitated and they're more upset by being displaced from their environment, they may also have other medical problems and health concerns that get further in the mix of how we're trying to figure out what's going on with him. So if somebody is significantly distressed by disaster and they have prolonged subsequent events, you know, the individuals might become confused, disoriented, unable to recall their names, their diagnoses, what medications they need, or in what dose, or who to, you know, call on their behalf, and generally just not seem to, you know, fit in well with the system that we create for them in the shelter. So it's very common that in my experience in these situations I'm called upon to go and talk to somebody to help assess things, because the other individuals that have tried to work with them who aren't used to working with the seriously mentally ill are a little frightened of them, or they can be very aggressively pushed aside, the helpers. And then the dilemma there becomes whether if they're agitated, despite all the helpful policies, you may end up wanting to call the police. Usually in a shelter situation, there are a lot of police around, and one of the roles that we ended up playing often was trying to intervene to keep things calmer before people got ejected from the shelter because they were viewed as a threat to the other members. And sometimes that includes just a calm, you know, presence, understanding that a lot of the agitation and other symptoms might be related to a problem that the person's experiencing, my example I'll give quickly is when I was in Baton Rouge, there was a woman that was repeatedly known to be very difficult in circumstances around, when meals were being served, and very demanding, and then she would often be observed going back and forth and pacing, and people would try to talk to her and she'd get aggressive. And so eventually the question was, who do you call? And so they said, well, call mental health. And I came over and started just, listening to her and talking to her, and very quickly figured out. She said, you're a psychiatrist, aren't you? And I said, yes. And she said, well, I know about all you people. I've been in the state hospital. And then she proceeded to roll off the meds that she'd been on and what her needs were. And she was really angry because she said that she had certain nutritional needs that people weren't paying attention to. And I said, well, I can help you with that. So I was able to take her over to the meal area, and we figured out what she could and she couldn't eat. And she settled down quite a bit. And then she said, well, I have some other needs. And she talked about the problem that she was having with incontinence. It sounded like she might have a urinary tract infection. So I took her over to health services, and they were able to help her out. So that would be an example of, in these circumstances, how simple things that you can do and the knowledge that you have can be effectively applied. This is an emphasis on this slide with that disaster preparedness planning, just a pitch, really. Needs to take into account all of these various factors. And so one of the things that you can do is, in this advocacy role, is not only if you're in a shelter situation, but in the community, make sure wherever you work, whether it's in a mental health clinic or a hospital setting, that there be some kind of plan that's available, knowledge about what to do in a disaster situation, so your patients can be given information about that. I think NAMI has some stuff, and there are other things, but that's really important in terms of what role we can play to help people, especially with what's going on. So let me talk about the Red Cross shelter in terms of everyone is welcome. So we've talked about how now we've deinstitutionalized, now the people with serious mental illness are in the community. We've talked about how the feds had to step in to make sure that the states were living up to their requirements. So we do have now individuals that are ostensibly more independent in their living and are more inclined to be directed to the shelters. A lot of people before might not choose to go to shelters. They tend to be homeless, or they tend to not have access. So the Red Cross has nicely stepped up and said, well, we really need to make people feel welcome regardless of their disabilities. We want to make sure that whether they have medical needs or mental health needs, that we're able to actually give them the chance to self-determination, that is to say, work with them as to what they desire and they say their needs are, while also trying to work within the context of a more traditional assessment for other needs that they might have. So this type of effort is really full bore. It's taught to everybody that's going to be working in shelter in the Red Cross. We have drills on it, and my observation is that it's more talk, it's real action. They take it very seriously, so that they even have people from national headquarters that are specialized in integration of people with disabilities, and they come to the area of a disaster and they will make the rounds at shelters, and if there are problems, they'll try to help hotshot figure out what is needed and how they can improve that level of service and care. So this, I'm going to just show you as an example of how they're trying to be much more friendly to the people who come to the shelter. This is a handout that's given to people when they arrive after they've registered, emphasizing the structure of being in there and what is expected of you, but also how you will be supported and how you can receive help in specific areas. So it's a 2-page handout. Children, it's worth noting, are parents' responsibility, and that is easy to write on paper. It is really hard to accomplish, I'll put it that way. And, parents in shelter circumstances are as overwhelmed as everybody else. We try to keep families together, but I will have to say that there are times when you need extraordinary types of additional support that's available, plus you need to have a little bit of a hard line with them at points. We have typically the states will provide social workers to come in to work with families that are already identified where abuse has occurred or there's neglect. And we do a variety of things to really help them. But we rely on other organizations. So Save the Children is really tremendous. They come in and they set up play areas and a lot of other services that would allow the parents during the daytime to get out, to look at their homes to see what's needed, to register with FEMA, to do other business to help get themselves ready to get out of the shelter. So that's really critical. Again, when I was in Baton Rouge, we had a real serious problem with a whole group of children that were repeatedly out and about. We didn't understand where they belonged, who were their parents. They couldn't tell us because they're often even preschoolers. And what I realized from looking at the situation and talking to people was we had no ID for them. The way they registered a family member and they got banded, but that was it. So finally my intervention was to talk to the managers, and we agreed that they would go back and reband all family members, and particularly kids, so that you could scan and find out who they were, who their parent was, and how to help, particular ones that were more problematic. What were the needs of that family that required that person, that mother, might be a single mother, or a mother and father, to get additional services that we weren't providing. So that's an important part of that. So the policy of everyone's welcome is meant to be not just integration but inclusion. I think I've indicated that. And so again, the definition of integration here is incorporating access and functional needs to support all the disaster services, but the goal really is inclusion, which is that you want to be part of a whole community, feeling welcomed and feeling that you belong. And that's not a simple thing to do, because there are a lot of people find themselves all in the same situation in a shelter, regardless of what your circumstances were in the community before then. And so there are folks who don't generally have to get along with each other that are there. And I will say very quickly that one of my own observations has been that there's a self-selection process. Often when shelters open up, families figure out very quickly that members of their family they don't like or they don't get along with can go to the shelter. They don't have to put up with them anymore. So a lot of the folks that we get, we're trying to get them back to their families. We often find out they're there because their families really didn't want them there. And it's not an unkind thing to say in a way, because the number of people, you can have 20 family members in a 2-bedroom apartment when there's flooding and things like that, and the person who doesn't get along well with other people, it's not just a simple matter of I don't like you. It's like the whole group can't function. So we have to sort of understand that and work with that issue. So how do we, again, understand what the needs are for all of these folks? The CMIS model is the framework that we use. The acronym is for communication, maintaining health, independence, and then you cram 3 S's together. So that's safety, support services, and self-determination, and then transportation. And I'm going to walk you through kind of the worksheet that we use and then talk about each of those elements. So this is the worksheet that we use in the Red Cross. Actually, even before we have to use this worksheet, when you actually register, there's a whole list of questions that we go through to also get at whether you have problems with hearing, vision, whether you have other special medical needs. So there's an early screening triage process to get people to, say, disaster health services. And so the registration process might be the first step, and this would be the second step to get into the detail of what is the needs of the person. We don't allow unaccompanied minors in shelters, so if we are trying to register a child and there's no parent or identified relative that can be responsible for them, then we contact the Department of Social Services, who are also at the registration table to help us figure out what to do. It's not that we won't provide them care, but we just need to make sure that we're appropriately handling the situation, and there's a very good reason for that. There is a very high rate of child trafficking, kidnapping of children, and the sex industry, unfortunately, takes advantage of these circumstances. So if there's any level of intense scrutiny that you could observe, it's going to be around trying to protect children. So that's an important element to be aware of. So again, we've got the various components that we've outlined for the CMIST here, but the important element to show you is that we identified a need and then there's a action plan. So I think the structure that the Red Cross, and this has been developed through FEMA as well, that's very helpful, is that there's some consistency and standardization of how we systematically look at these problems. And again, it's one thing to put it down on paper, but invariably you as the volunteer are going to be brought in to try and help out with some of these things, and nothing is always as simple as it appears on paper. So you have to use your wits and your own knowledge, and so here's the other elements to go with that. So let's talk about the basic elements. Communication. As I indicated earlier, people under stress have a lot of difficulty remembering things. So good luck remembering your phone number, your address, your social security number, whatever you need to have, your FEMA number, is not easy. But individuals who already come with those impairments are going to have significant problems. So we really try to make sure that our knowledge and our ability to identify these problems and bring in the right resources is going to be an essential element of the CMIST process. English proficiency is a big issue, especially here in North Carolina during Hurricane Matthew. There were whole communities of undocumented Hispanic immigrants who refused to come to shelters because they were worried they'd be deported. And so the consequence of that was that they put themselves at greater risk by trying to take care of themselves in circumstances where they often had flash floods and other things. And so one of the things that we ended up doing was outreach, and so mental health would often be called upon to go with health services, and we would drive out to an area where we had heard, and this is often through social media these days, that there was an endangerment, and then we would try to work with the folks there, and then we, on one occasion, set up an alternative shelter for that population with a local church. Of course, we got a lot of negative feedback from the higher-ups because they're also very careful about what the buildings are that you use. They have to meet code for safety, and it's really complicated to know all the detail of what you have to go through. And here we were doing an ad hoc kind of arrangement under the guidance of essentially being Red Cross shelter, and we were told on no certain terms that we couldn't identify it as a Red Cross shelter because it didn't meet all their requirements, but we did anyway help them out that way, and then also advocated for other resources. But communication was a big issue here because folks didn't understand what we were doing very often at the outset of our offering help, and they were frightened that we were going to be another kind of authority that would be putting them at risk. So again, being able to communicate is really critical. Another area, so under communication, is going to be autism. So there are significant numbers of folks that I've encountered in the shelter circumstances who are autistic. The way you communicate is very different, and very often there are a number of elements to their behavior that typically you might try to interpret as agitation and then calm people down and restrict things, and that makes it worse. So again, it's very important if they have a caregiver to ask, does your child have autism, or is it, what's the baseline here, and how should we handle the situation? And really nicely, a lot of the advocacy groups for autism are involved in shelter work. There is a family advocate for autism that's going to talk to the Disaster Health Services folks here in a couple of weeks, and I was communicating her a little bit about some of the things that I'd seen and what we were using, just to be on the same page. And I found it very, very useful to have them there. They provide materials for the kids, and that becomes an important part of what we're trying to do for getting people calm and their needs met. So maintaining health, the issue here, which is another category, is that you want to provide assistance that's going to provide all the appropriate care and equipment, and this works towards, again, independence, making sure people are able to take care of themselves. Again, in the situation in sheltering, it's not uncommon that minority and low-income communities have more severe limited access to health and medical services, and that we want to ensure that there is access and functional needs that are critical that get met. So facilitating dialysis appointments, dealing with people who are having cardiac failure, and ensuring that they have continued access becomes really important. So in my work, again, in these circumstances, very often it seems as if we have sicker people than you would normally expect to see, but again, that's often because they come from impoverished circumstances, and their health care is not great to start with. So we are often actually able in the shelter circumstances maybe to provide even better supportive case management care than they might otherwise have had. So providing some consistencies and follow-up to that is important. So medications are important here. The fact that a person requires medication is not a basis for excluding them from the population shelter, and the plan should include procedures for obtaining, storing, dispensing, and documenting medications. So a big part of what the nurses do is related to this right here. Client medications are their property, and they must have access to their medications at all times. For those that are on methadone, if there's a state plan, disaster health services work with the local public health department to identify a private area for dispensing the meds. Sometimes it means transporting them to those areas if it's outside the shelter and making sure they get back. Lo and behold, medical marijuana. Red Cross actually has a policy on that. The need for medical marijuana must be reported to disaster health services, and if you're in a state where it's legalized medical marijuana, then we provide assistance for, again, as if it were medicine for replacement and prescription, but they still cannot smoke in the shelter. So independence, that is, again, a lot of this is sort of building on each other. That is an overall goal. We want people to able to get the level of assistance to maintain independence in their daily activities. So that might include service animals, personal assistance services, or caregivers, supplying needed support to really get a quick restoration to a pre-disaster level of independence is our goal. Safety support services and self-determination is the next 3S's part of that CMIST. And we know that individuals may well lose the support of personal assistance services, family or friends, and they have difficulty in a new environment. So particularly here, again, autism, dementia, Alzheimer's, and other pre-existing mental health conditions such as schizophrenia or intense anxiety are challenges. And if separated from the caregivers, young children can't identify themselves and when they're in danger. So I can think of very quickly a circumstance where somebody was subject to panic attacks and was requesting special accommodation for that. In that circumstance, all we could do was show them a very small room with no windows, which where you could go and relax. Well, they had claustrophobia, so they very quickly determined that actually leaving the shelter and being outside for periods of time as their escape mechanism was better, and that was what we kind of came up with for a compromise. So again, quiet areas. FEMA does say that we should include a strategy providing a quiet area with each population shelter and try to relieve stress, try to limit the amount of noise and overstimulation. It is really hard to be in those circumstances. There is no privacy. Everybody's into everybody else's business, and it's very stressful. So this is what I did in Baton Rouge. I helped set up this blue room for autistic children, and I learned a lesson there because I had never known that you could create such a thing, and there, it turns out, are specialized panels that are designed for that. And I was very skeptical, did it, and then I was working with a group of families, and then I was really gratified to learn subsequently that they found how helpful that had been, that they had no place previously that they could go to where the kids weren't just, jacked up from all the stimulation and overwhelmed. So it's good to know. Let's talk about domestic violence. There's an increase in the disaster circumstances for domestic violence because of the stress, and also potentially for relapse of symptoms related to depression, anxiety, and substance use. But in these sort of chaotic situations, the perpetrator for domestic violence often feel a loss of control, and that may then be followed by becoming abusive in order to gain back a sense of control in the relationship. And so we have to be very mindful and concerned about that. I certainly have personally witnessed a lot of that in the shelter circumstance. And so, again, anticipating that that might be an issue, if people look frightened, just having a casual conversation and beginning to understand that there might be that history, there are things that you can do to avert and prevent or at least mitigate those instances is really important. We have the data that after Hurricane Andrew in Miami, that the domestic violence calls to the community helpline increased by 50%. And after the 1993 floods in Missouri, again, the number of people that were trying to get into domestic violence shelters went up by 110%. And following Hurricane Katrina, the domestic violence increased by 45%. So what can we do? We can identify safe and secure shelter options for families experiencing disaster and domestic violence. A physical shelter facility that's operated by a domestic violence program that serves victims is important. So one of the first things whenever I arrive in a shelter that I like to find out about is what are the local resources that we do know about. And that includes not only health services and mental health services, but I look for, again, shelters for families where domestic violence has been a problem. I can think of one particular woman that we helped, but to get to one, it took a lot of work, and we had to send her halfway across the state of Louisiana to get there. But she was pregnant, and it was a special shelter for pregnant women where domestic violence had occurred, and she felt very unsafe and had other psychiatric, psychological issues, and that seemed to be the best solution for her. So that would be one example I can think of. So we also will use those circumstances if there is, say, a motel available, to send them to a motel where there's hopefully going to be a safer circumstances. So shelter animals, American Disabilities Act. So any dog that is individually trained to do work or perform tasks for the benefit of an individual with a disability, including physical, sensory, psychiatric, intellectual, or other. And in shelters, service animals are not pets. You can see a service pony there. The Red Cross assists the owner with providing food and supplies when needed. Your region has the discretion to allow assistance animals in shelters. So again, the strict definition of a service animal may not be met, and depending upon the circumstance and what's going on, you may allow other an animal in that doesn't seem to fully meet the need, but that's a matter of discretion, and it's not always easy to permit. And service animals help people with disabilities and others with access and functional needs for independence. So service animals handler is responsible for the animal's care and feeding, although we do provide as best we can. We have arrangements with veterinary services and also for food. They have to clean up after the animal. Person with a disability cannot be asked to remove the service animal from the premises unless the animal is out of control and the animal owner does not take effective action to control it. The animal poses a direct threat to the health and safety of others. I will say that in general, pets and service animals are almost, and maybe actually, the most contentious area that I've had to deal with and my colleagues in these sheltering situations. We had a near riot in the mega shelter in Baton Rouge around the care of pets, and these weren't just service animals. So all of your negotiation skills and your compassion and your willingness to negotiate and have compromises is really critically important. In the end, we averted that by finding an alternative shelter in a rural area. But more importantly, it was access to the pets that every day on a bus with a mental health person, and that was like one of our, most desirable activities for the day, is to get on the bus and go out to the country to a shelter. But their ability to get out and see the pets and to be with them and spend quality time was hugely important. So again, animals are really a very important part of our ability to provide the support. The last part here is transportation, and I can't emphasize enough that when you identify all the resources that are locally available and even kids getting back to school, which is hugely important, if you can't transport people out to those resources, you're in serious trouble. And so we put a high priority on including the local public transport people in the shelter circumstances, trying to figure out with them, can they run certain routes, what time of day can they run, how can we work with them as far as how we can get people to the right bus area in order to get where they had to go, whether it's to work or to some other circumstance. So it is a really important area. So I'm going to end by just saying that, identifying resources and building relationships, working with partners in the community is hugely important. And I think that emphasis has been informed by the fact that we've discovered increasingly that we tend, if we're not ourselves with a disability, thinking of that being something that we really have to worry about, that somebody else will take care of it. Well, it turns out that somebody else actually is us. And so that's an important part of our role in healthcare. Do I have time for questions? Okay.